Okay, I think we are live on YouTube, which is fun. Okay, I'm admitting everyone. You guys can see my slide? Wonderful. Okay, welcome everyone. I'm admitting everyone. 7 o'clock. I need to mute. You guys can see my slide? Wonderful. Forgot how to do that. Okay, welcome everyone. I'm admitting everyone. 7 o'clock. Okay, can you hear me? Yes, wonderful. Okay. And you can see my title slide. Correct?
We can see it.
Okay, so we're going to go ahead and get started. Thank you for joining us on this second session for the Foundations in Critical Care webinar series focused on critical care for patients across the globe. I'm very excited to have a great lineup of international panelists. Today we have Dr. Rachel Kimani, who is from Bagathi County Hospital in Kenya, Dr. Andrea Komisky from Stanford University, Dr. Natalie Tett, also at Stanford University. Dr. Andrea and Dr. Natalie are both emergency medicine physicians. Dr. Sammy Benjamil and Dr. Joseph Forrester, also at Stanford University, are our surgical colleagues. Dr. Papicho Ntambe and myself are anesthesiologists, as is Rachel. So we want to start our second webinar. Today we're talking about hypovolemic and hemorrhagic shock. A few housekeeping slides just to remind us to be respectful. This is a safe space for individuals from lots of different backgrounds. We want to learn together. And so we want to be kind and respectful if we disagree with something. We will be using the Q&A function at the bottom of the screen. Please send questions through the Q&A box and feel free to introduce yourself in the chat box. If your bandwidth permits, you're encouraged to turn on your video and capture your face or the room if you're in a group. The session is being recorded and your attendance is your consent to being recorded. This session will be posted also on the Learning Resource Center and streamed live on YouTube. I will put the link to the Learning Resource Center in the chat box in just a minute. Closed captioning is available. You can see this at the bottom of your screen. This is helpful, especially for those for whom English is not a first language. All slides are free and open access. You can download the slides and also see our resource library. All of this is available and free for offline use. They can be found on the Learning Resource Center, which you can access using the QR code seen here. And again, I will put that link in the chat box. Participants attending the full session will automatically receive a certificate of attendance. You will also receive an email notification from Stanford's CME or Continuing Medical Education Office. That email will contain a link. It's optional, but you can complete an evaluation and you can receive CME credit from Stanford's CME office. So look out for that email that will be sent to the email that you use during registration. And with that, we are going to switch over to Dr. Komisky, and thank you again for joining us on this second part of our four-part series of shock in the Foundations in Critical Care series.
It says that you've enabled screen sharing, so I need you to allow it for me.
Okay, so this is session number 2 of a 4-part series on shock. According to UpToDate, shock is defined as a state of cellular and tissue hypoxia due to either reduced oxygen delivery, increased oxygen consumption, inadequate oxygen utilization.
Okay, so
or
this
a
is
combination
session.
Okay, apologies. Can you hear me now?
Yes.
Can you hear me now, Andrea?
Yeah,
Yes, we can hear you.
but it's not. It keeps breaking.
Okay, can you hear me? Nice. Okay, sorry about that. Shock is defined as either reduced oxygen delivery, increased tissue hypoxemia due to increased oxygen consumption or inadequate utilization, or a combination of these processes. Because inadequate oxygen delivery is the most common cause, we will be discussing these mechanisms of shock in this series. Shock is initially a reversible condition. However, if it's not recognized and treated early, it rapidly becomes life-threatening and can lead to multiple organ failure and death. Shock can be described in 4 categories: cardiogenic, obstructive, distributive, and hypovolemic. In the last session, we discussed distributive shock. We will cover each of these categories in separate sessions. We'll refer back often to this one-pager called Approach to Differentiated Shock. This one-pager is available for download on the Learning Resource Center, or you can scan the QR code here to access it directly. It's important to remember that many patients have multifactorial shock. For example, a patient can have distributive shock and cardiogenic shock. So it's important for us to recognize and treat these causes simultaneously. Today, we will focus on hypovolemic shock. If you think of blood pressure as a perfusion, if you think of blood pressure and perfusion as tank, pump, and pipes systems, hypovolemia is a tank problem. As a refresher, let's quickly talk about blood pressure. Oxygen is delivered to cells by circulating blood. Because we cannot measure circulation, oxygen, and blood at each and every cell, blood pressure is the best substitute to measure blood perfusion to the cells. We will discuss blood pressure with the understanding that it is created by the product of cardiac output and systemic vascular resistance. Cardiac output is generated by the heart. It's equal to the volume pumped from the heart in 1 minute. So it is measured in liters per minute. This volume is determined by the stroke volume generated by the heart multiplied by the number of heartbeats per minute. Stroke volume, or the volume of blood leaving the ventricle during contraction, is the resultant of preload, contractility, and afterload. Systemic vascular resistance, or SVR, is the force or resistance exerted on the circulating blood by the blood vessels. The resistance is determined by the length of the vessels, the diameter of the vessels, and the viscosity of the blood. SVR is also a force that the left ventricle must overcome to pump the blood out of the heart into the aorta and the rest of the arteries in the body. So today we are discussing hypovolemic shock.
So as we move through the discussion, it is important to remember that shock is a life-threatening condition. It is a medical emergency. Shock is most commonly
I can't hear
associated.
Andrea. Can others? Okay, great.
Shock is most commonly associated with circulatory failure, resulting in inadequate oxygen delivery to the cells. Inadequate oxygen delivery then results in cellular and tissue hypoxia, and this can lead to cell death, tissue death, and organ dysfunction. If not reversed quickly, then the shock will become fatal for the patient. So important to remember. Through this case-based discussion on hypovolemic shock, we will hope to achieve the following objectives for everyone. So we will be able to recite the equation for blood pressure as blood pressure equals cardiac output times SVR, list the 4 categories of shock, identify shock as a medical emergency, list the common etiologies of hypovolemic shock, recognize the signs and symptoms of hypovolemic shock, be able to recognize hypovolemic shock early, understand the principles of management and treatment steps for hypovolemic shock, apply effective transfusion strategies, as well as be able to monitor volume status in a patient. Today, we will be taking care of Mr. Chen. As Mr. Chen's provider, you are a junior doctor in the emergency department at a busy level 1 trauma center. You are notified of an incoming trauma due to a motorbike collision. The patient is a 50-year-old male on a motorcycle who was hit by a car going approximately 50 kilometers per hour, 15 minutes prior to arrival. He was conscious but disoriented with multiple abrasions and bruises, and there are no obvious external signs of bleeding. The patient reports a history of congestive heart failure for which he takes furosemide. Pre-hospital interventions performed by your EMS are cervical collar was placed. He was put on 10 liters of oxygen mask per minute, and 2 large bore peripheral IVs were placed, and 500 milliliters of normal saline was infused. Upon arrival to the emergency department, his initial vitals were notable for a heart rate of 100, a blood pressure of 100/60, a respiratory rate of 28, and an oxygen saturation of 94%. And as you can note, he is slightly tachycardic, however, it's still within normal limits. His blood pressure is noted to be low, with a systolic blood pressure of 100, with a MAP calculated to be 73, however, and his respiratory rate is noted to be fast at 28. His SpO2 is acceptable, however, he is requiring 10 liters of oxygen mask.
So septic shock, a form of distributed shock, is the most common form of shock presenting in high-resource setting. In one study, sepsis was the etiology of shock 62% of the time. Cardiogenic and hypovolemic shock each represent an additional 15% each. Other forms of distributed shock, such as anaphylaxis, presented in 4% of shock cases. And obstructive shock is much rare at approximately 2% of shock presentation. However, the etiology of shock varies by setting. For example, large urban hospital may see more trauma and therefore carry a greater percentage of hemorrhagic or hypovolemic shock. Additionally, there is often incomplete information about shock data in lower resource setting, so the exact epidemiology is challenging to describe. So Mr. Chen was in a motor traffic accident and suffered trauma. What are the 5 key steps in the primary survey assessment of the trauma patients? So A, airway assessment and protection, including cervical spine stabilization. B, breathing, ensure adequate ventilation and oxygenation. C, circulation, stop bleeding, and ensure an organ perfusion. D, for disability, ensure neurologic and cognition is intact. E is for exposure, environment, assessing for injuries and preventing hypothermia. So these are the findings on the primary and secondary survey for Mr. Chen. So primary A and B, his airway and breathing are not compromised as he's able to speak in full sentences and his lungs are clear. However, he does need some supplemental oxygen. C, circulation is a concern as his skin is cool and pale with a delayed cap refill. These are signs of poor perfusion. Ideally, you should stop here and address the possible problems with circulation before moving on to the assessment. Find the bleeding, stop the bleeding. And under D, Mr. Chen is moving all extremities and is alert, although disoriented. He has a cervical spine collar in place, but does not demonstrate signs or symptoms of neurologic injury currently. E, environment is safe, as patient is now in the emergency department. Additional injuries have been described. The patient is normothermic. So I'd like you guys to answer in the chat box. So for Mr. Chen, what do you think is the most likely cause of hypotension and tachycardia? And I give you some time.
So we encourage all of the learners and participants to put their answers in the chat box. We'll give you 5 more seconds. Okay, Dr. Natalie.
It's great to hear the responses. Yes, the answer is A, hypovolemic shock. So tension pneumothorax would lead to unilateral loss of breath sound and circulatory collapse. So he seems to have bilateral breath sound. So, so obstructive shock, tension pneumothorax is not likely. Neurogenic shock occurs with damage to the brain or spinal cord, but Mr. Chen appears to be moving his extremity and is intact cognitively. Cardiogenic shock is possible, but less likely in this acute trauma setting. Intracranial hemorrhage is also possible, but less likely since Mr. Chen does not lose consciousness, is neurologically intact, and did not hit his head.
So next, we are going to reassess the patient, Mr. Chen. And if you note, he has true tachycardia with a heart rate of 150. He has hypotension that's worsening with a blood pressure of 70/40. And despite having supplemental oxygen of 10 liters, his SpO2 is dropping to 92%. While in the emergency department, you performed a fast exam and noted that it was negative for free fluid. And Mr. Chen is receiving oxygen through and also has his 2 large bore IVs, both of which are size 18 gauge. And he has received the 500 liters of normal saline. You've gotten a chest x-ray and a pelvic x-ray displayed here. And so my question to you all is, which is the next best step for the patient who's presenting with shock, abdominal tenderness, and pelvic instability with the imaging findings?
Okay, everyone put your answers in the chat box and I'll give you 15 more seconds. Okay, Dr. Kaminsky, what's the answer?
Excellent. The answer is C, place a pelvic binder and transfuse blood. Mr. Chen at this point is very clearly in florid hemorrhagic shock. Most notably here has a very large open pelvic fracture. Next for this, we will have Dr. Kamani talk to us about the blood transfusion practices. The questions that we will be addressing are, why is blood component therapy more common than whole blood? And when should whole blood be used? When should platelets be given? And when should plasma be given?
So sorry. Am I audible? I don't know.
Yes, we can hear you.
Okay. So the next slide. Thank you, Andrea. So we are trying to understand what are the transfusion practices that should be executed in this kind of a patient. When do we decide that we're going to give blood, and when do we decide that we're going to give platelets? We're having an issue of the pump. And so with an issue of the pump, you want to fill the tank, because the tank is empty. So you want to decide which component is best. In these cases whereby you have reduced, the tank is empty and you need to have fluid or you need to have blood, you need to give whole blood, because at that point you want to improve all the parameters that are there. And then based on what your blood works will show, if you're having low platelets and all, you can opt to also give you can opt to replace with platelets. However, if you're going to if you're going to have a massive transfusion, you also need to consider giving fresh frozen plasma, so that you can improve on the clotting factors. And that is some of the clotting factors that you'd want to improve is factor 2, factor 5, and all the others, so that they can improve the tank, and you can have blood being available to the patient. And also other things to consider is, will you give tranexamic acid or not? What tranexamic acid does help with is to at least reduce the risk of bleeding, since it's an antifibrinolytic, and it helps to prevent or treat bleeding. So in cases of trauma and tranexamic acid is one of the things that should be considered and should be supplemented for the patient.
I would like to maybe hear from some of the other panelists, maybe Dr. Papicho or Dr. Forrester. Historically, we've actually used whole blood for transfusions, and that's still very common, for example, in military situations. But now we see more commonly blood, when donated, is divided up into different components. So Dr. Forrester, what is your understanding of why we don't use whole blood more often when whole blood is used?
Yeah, thank you so much, Dr. Crawford, and great question. So there's been an increasing trend in the trauma literature to administer whole blood in the setting of hemorrhagic shock from trauma. There have been several large studies that have supported its use. I think the reason many centers still don't use whole blood is there are differences in how it has to be kept compared to component therapy. And for large centers that perform, liver transplant or cardiac surgery, the data isn't as supportive of whole blood use. So from an institutional standpoint, there's a cost benefit that analysis that has to be done to determine, depending on the trauma volume and the need for whole blood, how is that offset by the need for component therapy in patients undergoing liver transplant or cardiac surgery?
Another place where I've seen whole blood used is in obstetrics. Does anyone on this panel have experience giving whole blood for maternal hemorrhage?
Yes, Anna, I can come in and say something for maternal. We have quite a number of maternal hemorrhage in our environment, and whole blood, it's what we often give for different reasons, maybe because it contains already or other factors and other components that the blood have that the patient might need at the time that you are giving your transfusion. And maybe for another reason is we're not always in the situation of dividing blood and the component. So you just force yourself to give the whole blood as it is. So if the whole blood is available on the time when you need it, I will advise our colleague to give it as it is.
I think that's a good segue, if I may, Dr. Komisky, to allow Dr. Papicho to tell us a little bit more about those barriers. Sometimes we don't have component therapy, and sometimes it's difficult to get blood for transfusion at all. So Dr. Papicha, would you mind telling us some of the barriers that you have seen and about this paper that you published on the barriers to transfusion in resource-constrained settings?
Thank you, Anna. For sure, there are so many barriers that we can face. You can have blood, but you fail to give it. Or sometimes you don't have blood at all for different reasons that we can share with our colleagues. It's known that
Dr. Papicha, I think you're muted. Could you unmute perhaps?
am I audible now?
Yes, you are. Sorry.
Oh, sorry for that, Anna. Sorry to our panelists for that. I was saying, sometimes you can have blood and you fail to give it. Or sometimes you don't have blood when it's really needed. Sorry, there's a back.
Yeah, I'm trying to mute them. Go ahead and continue.
Yeah, so thank you very much. In this research that we did some few years ago, we sent a questionnaire to our colleagues in different countries, approximately 10 countries in resource-constrained areas. We asked them to find out what could be the reason, the challenges that they face when they need blood, or why is blood not available at all. And then as a result, we were told that there are different barriers to blood transfusion. It could be cultural or infrastructure barriers. Okay, the barriers are encountered either at donation time, whereby sometimes the testing kits are not available, or if they are there, they are not enough to test all the blood that you collect. So that is going to contribute in having less blood available to be distributed in different areas. So also, you can have kits or everything available, but the donors that are coming there, they request for some few incentives. And then so giving them those incentives, they're going to give you blood. Or the donors are seasonal. Like this time when it's farming time, the donors, they've migrated, they've gone into the farms. When you go for collection this time, you might not get them. So that can end up by not having enough blood available in all the institutions that are depending on that collection center. So all these barriers put together, they can give you challenges in terms of taking care of an hypovolemic patient who's in your institution. So in such situation, it's really a big challenge to take care of such patients. So you now rely for different centers. And those hospitals in the rural centers, they cannot keep a big volume of blood because they are restricted in terms of the blood keeping capability. So they rely on a center that is located far. And then when you need blood, you need transportation for you to take it there. And remember, it's not so easy to mobilize blood and send it in a very short time when the patient needs it for you to fill up the tank.
Yeah, thank you so much. I think it's really interesting because some places have whole blood, some patients have, or some places have component therapy, but on the donation side of things, there's also lots of barriers. So it's not just about infrastructure, it's also about culture and donation as well. Thank you so much for your work in that area and for sharing that with us.
All right, I'm going to talk about how to start the discussion off on how to properly start resuscitating after a patient's been identified with hemorrhagic shock. Once this has been identified, you have to act quite quickly to stabilize and reverse this life-threatening condition. First and foremost, you must have reliable venous access. This is paramount in resuscitation and transfusion, as well as giving other essential medications. In general, the best catheter is going to be something that's shorter in length and larger in diameter. This will allow you to transfuse blood at the highest rate by decreasing the resistance and speed of infusion. Typically, a recommendation is to give 2 18-gauge or larger peripheral catheters. Traditional central lines are long and smaller gauge, so it's important to not be fooled by thinking just because it's a central line that you're going to be able to transfuse effectively. In fact, it's the opposite. So putting in a triple lumen central line will not be beneficial, and in fact is far worse than an 18-gauge IV. If you are going to use central access, then you should consider a large bore line such as a cordis introducer, at least an 8.5 French. Another caveat is blood can be given through an intraosseous line, but it is less than ideal. Sometimes we have patients arrive with only intraosseous lines. It's okay to start transfusing through them, but that is not a substitute to properly securing a large bore IV access. During a massive transfusion protocol, the ratio of blood components to be used is approximately 1:1:1, being red blood cells, plasma, and platelets. If whole blood is available, as discussed before, then in the trauma situation, it is ideal. But as mentioned, there's a lot of logistical and institutional factors involved in being able to transfuse whole blood.
Thank you, Dr. Benjamin. I think this is such an important point that I actually want to stress it again and reiterate to all of the learners that not everybody has central lines, not everybody has large bore introducers such as a cordis introducer. But it's really important that if you suspect hypovolemia, and especially if you think that hypovolemia is from hemorrhage or hemorrhagic shock, it's the very first step is to place 2 large bore peripheral IVs. When we talk about large bore peripheral IVs, ideally it would be 18 gauge or larger, so 18, 16, 14 gauge IVs. However, if you have a well-running IV that's in a more proximal vein, such as the antecubital location or higher, you can actually run even the large volume resuscitators such as Belmont's or the level 1 transfusion apparatus. You can run large amounts of volume through a well-running peripheral IV as long as it is proximal. So again, it's super important to realize that that peripheral IV that's large bore is better than a central line when it comes to giving large volumes of fluid quickly.
I think that can't be underscored enough, Dr. Crawford. I think it's really tempting to try and put in central lines or trying to put in cortices, but at the end of the day, the absolute best line is a large bore IV.
Yeah, I agree. And I think that's that people are thinking maybe about 2 things at the same time. On one hand, we want to give large volumes of fluid for hemorrhagic shock. And so for that, you need something more large bore. However, people are also probably at some level thinking maybe we have to start vasopressors on this patient. And so from the sepsis and septic shock literature and from our previous discussions on distributive shock, it's important to remember that if needed in an emergency situation, you can run vasopressors temporarily through a peripheral line, again, as long as it's a well-running peripheral IV in an AC location or higher. So yeah, I think it's incredibly important to understand for large volumes of fluid, we need to have good IV access, and that's usually not the central line. Can you, Dr. Forster and Dr. Benjamin, tell us a little bit more about the transfusion literature? How much blood do we give? When do we give platelets? When do we give FFP? What is some of the literature there?
Dr. Benjamin, you want to start?
Sure. So there's been quite a bit of literature surrounding the optimal way to transfuse. We've already discussed that in trauma scenarios, if you have whole blood readily available, then this can be the ideal product to use. But most hospitals in the United States don't have whole blood readily available. It's fractionated to components. Military studies did show that the ratio of blood product transfusion does have a pretty significant effect on patient outcomes. In patients in combat-related trauma requiring massive transfusion, a high about 1 to 1.4 plasma to red blood cell ratio improves survival. And then for low, medium, and high plasma to RBC ratios, overall mortality rates were 65, 34, and 19, and hemorrhage mortality rates were also improved from 92.5 to 37%. Those were in the military literature. There was a big civilian study that sought to replicate this data as well. And it did compare 1:1:1 versus 1:1:2. And this did show that the 1:1:1 group, meaning red blood cells, plasma, and platelets group, had significantly lower death from exsanguination in both the first 24 hours and also 30-day mortality. So in summary, the ratio of blood of the red blood cells, plasma, and platelets must, as much as possible, approach 1:1:1 for improved patient outcomes during a massive transfusion scenario. Dr. Forrester, did you have anything to add to that before we start on the TXA?
Yeah, there's some questions in the chat about the timing and which product to go first. I think some of it depends on what you have available. I think there's an increasing amount of literature to demonstrate that an FFP first process works better. But the reality is in someone who's in hemorrhagic shock, I think, you know, if you have the luxury of deciding between FFP and blood for the first product that's going in, I would choose FFP. But the reality is this patient needs volume. So either I think will work as long as you're ultimately reaching a 1:1:1 ratio or using whole blood. The other thing to consider is that platelets don't necessarily work with all rapid transfusers. So depending on the rapid transfusion system you have and the resources that are available, you might want to think about how you're administering the platelets.
One thing I would kind of add on it can be difficult to say exactly how much blood somebody needs. I think a lot of this just comes down to experience, understanding what the context is, and then how the patient presents. One thing you don't want to do is use hemoglobin as a measure of where your resuscitation is. The hemoglobin concentration, oftentimes in acute bleeding, the blood levels have not yet equilibrated, so hemoglobin is going to be extremely inaccurate in determining if you've given enough blood product. So that's something that's very important to consider as well.
Also,
can I ask you guys to speak a little bit more about the comment on platelets and rapid transfusion? I think I'm going to make an assumption that most people don't have Belmonts and level 1 transfusers unless they're at a level 1 trauma center or a larger tertiary hospital. So many of us are really just putting a pressure bag or some sort of pressurized device on top of the blood components. Tell us a little bit more about platelets and rapid transfusion.
So it's I mean, you can squeeze platelets in. The issue, at least for the rapid transfusers, is not all of them will handle the platelet bags, but you can use it and just squeeze it in. The other thing I'd say is that anytime you have someone who's massively bleeding, like the patient in this case scenario, anytime you're thinking about what you're transfusing, you also want to be thinking about calcium and making sure that calcium is going in at the same time. Just because you'll almost certainly drop your calcium with this degree of transfusion.
All right. We'll continue discussion with tranexamic acid. Tranexamic acid is something that's pretty widely available and used quite a bit in hemorrhagic shock situations. It's an anti-fibrolytic agent that strengthens blood clots once they form. As many uses can decrease the amount of bleeding, decrease the amount of transfusion need, but it's been proven to be more effective in some scenarios and in some situations potentially harmful. In trauma, the standard guideline is to give 1 gram over 10 minutes within 3 hours, followed by an additional gram over 8 hours. There is some research about changing the concentration and timing of this, but for now, most places are still doing 1 gram over 10 minutes and then followed by an additional gram over 8 hours. This has been shown to reduce mortality in 1 month and 24 hours from exsanguination. TXA is also used quite often in postpartum hemorrhage, also showing that there's a benefit to helping with hemorrhagic shock and bleeding without increasing thrombolytic events. But in gastrointestinal GI hemorrhagic shock, the data is not as clear, and it actually has been demonstrated that potentially there's more harm than good. It has been shown that there is an increased risk of adverse effects such as DVTs and PEs. So in GI bleed, it's a little bit less clear if TXA, if the benefit of TXA outweighs the risk. Dr. Forrester, do you have anything to add?
No, thank you.
So the signs and symptoms when you have hypovolemic shock is you're trying to understand why is the tank empty? What's causing the tank empty? So what are you dealing with the patient? So in hypovolemic shock, the different causes there are different scenarios that can lead to hypovolemic shock. So most commonly than not, we have hemorrhage. So in hemorrhage, you're thinking about, is it a surgical case where you're doing a cardiac surgery? Have you lost so much blood? Is it trauma? The type of trauma that you'd probably have more frequently would be maybe fracture femur or pelvic fracture. There's also skin losses. In skin losses, we have scenarios like in burn patients, whereby burn patients tend to lose a lot of fluid, so they tend to present with signs of hypovolemic shock. You have GI losses, excessive diarrhea and vomiting that you need to resolve fast. There's also third space volume loss. You're thinking of patients who have pancreatitis, and in such patients, they may present with tachycardia and all the other signs and symptoms of hypovolemic shock. There's renal wasting and also low per oral intake. So what this patient would present with is they have reduced capillary refill. So the tank is empty. So once they have this reduced capillary refill, you tend to have the central venous pressure also low. And how the body now tries to compensate for this is because it needs to maintain its cardiac output. What happens is the heart rate will increase. So you'll have a tachycardia because you're trying to pump in and to maintain the cardiac output. And at the same time as you're having your high heart rate, there's now they're trying to maintain the cardiac output. So the patient tends to present with some sort of hyperdynamic state. And then other ways of also being able to diagnose this is you have cold peripheries and your pulses are weak. You have extreme weak pulses in the extremities. I'll go to the next. So some of the key values that you'd want to also look at, what happens is you have the BUN and the creatinine ratio. It could go up. You have an increase in your lactate, which may be elevated due to the poor perfusion that you're having. The patient tends to have an anaerobic metabolism. And at the same time, there's reduced oxygen delivery into these tissues. So when there's reduced oxygen delivery, they have now an acidotic presentation. So your pH goes up, and this increase in pH leads to now an increase in the base deficit. One key thing is that you should not use, as earlier indicated, you should not use hemoglobin as a way to try and see whether your resuscitation mechanisms are improving, because it's not a good marker to show, especially when you're doing when you're trying to resuscitate through the patient through fluid replacement. And as I had earlier stated, also the CVP, which is measured through the neck veins, is low and should respond. The CVP responds extremely well as much as you continue resuscitating this patient, whereby you'll start noticing that your CVP is going up as you try and replace the fluids. So what are the most common etiologies of hypovolemic shock? Maybe I could give the participants to indicate in the chat box what could be. Sorry, I don't know. There's someone who's not muted their microphone. Something
Yeah,
that's
that's okay. I'm muting them as they come in. So just for the participants, please stay on mute. And also maybe try to list some of the most common etiologies of hypovolemic shock in the chat box for Dr. Rachel.
Yeah, I can see some are indicating trauma. Yeah, trauma is common. Burns, and there's burns trauma. Someone has said acute pancreatitis, PPH. Yeah, so all those are the common ones that we get to see in our practice. But to emphasize more is for the maternal population, we tend to also see a lot of postpartum hemorrhage, which can be very detrimental if we don't work on it. So what happens in postpartum hemorrhage? In postpartum hemorrhage, the tank is empty. So we want to try and ensure that we have ways that we can improve and ways that we can be able to resolve. Sorry about that. Because we all know that we have about 70,000 deaths that happen annually. 70,000, 14 million women die, and this have PPH, and at the end of it all, it has been documented about 60 to 70,000 deaths. So in the study that was conducted that showed the effectiveness of some of the interventions that were conducted, I think you can go to the next slide. Yeah, this one. Thank you. So where you want to detect and treat PPH. So in the emotive study, it was an issue of you want to early detect and understand what's happening with the patient. So once you realize that you're having PPH, what next? You massage the uterus for at least 1 minute. You give your oxytoxic drugs. Here you're thinking about oxytocin, whereby you give 10 international units in 200 to 500 mLs of crystalloid over 10 minutes. And then you also maintain with 20 international units for at least 4 hours. Tranexamic acid has also been shown and proven to be effective in this kind of setup of patients. And then you also have to have an eye of also wanting to give IV fluids through your second intravenous access, which you should be having as you're trying to resuscitate this patient. And you keep examining and seeing, are we improving or not? If you're not improving, what's your mode of escalation of care in your setup? What's the next step to help these patients? Don't know if Dr. Crawford
we recognize maternal hemorrhages is a very common source of hemorrhagic shock among many people across the globe, and we actually will have a session dedicated just to maternal hemorrhage later in the series.
Okay, thank you.
Great, thank you, Dr. Kamani. So one of the ways that we estimate the volume of blood loss is through this classification system of hemorrhagic shock, which is based mostly on vitals, also on mental status. So you can see in class 1 shock, less than 700 cc's, you don't really have many derangements. Your heart rate's normal, blood pressure, pulse pressure, respiratory rate, all normal, maybe a little bit of anxiety. But you can see already all the way up to, in class 2 shock, between 750 and 1500 milliliters, you start having a little bit of elevation of heart rate up to about 120, but your blood pressure is actually still normal. And maybe they're a little bit more anxious, but even though you've lost more than a liter of blood, your blood pressure is still normal. So this is something that potentially can fool people in terms of the severity of blood loss. When you get into class 3, 1500 to 2 liters, or about 30 to 40% of blood volume, then you start getting pretty significant tachycardia to 120, 140 as your blood pressure now starts to drop and your respiratory rate increases. And then patients are more anxious, confused, and potentially even combative. Once you're in class 4 shock, more than 2 liters or greater than 40%, you have an extremely fast heart rate, your blood pressure is significantly decreased, you have a narrowed pulse pressure, your respiratory rate is significantly increased, patients are confused, lethargic. These are pretty evident in terms of the severity when they come into the trauma bay.
One of the important things to underscore here is that the brain is one of the most kind of sensitive markers to hypoperfusion. And so the mental status really is an important marker and something to keep in mind when you're evaluating patients who are coming in with potential hemorrhagic shock. The other very subtle finding, but an important one, is the decreased pulse pressure, which also changes very early on and can be a sensitive marker in the potentially injured patient.
I could not agree more with you, Dr. Forrester, and have seen many times where a patient presents with altered mental status, confusion, anxiety, combativeness, et cetera, and it's really because of decreased perfusion and hypovolemia and decreased oxygen delivery. So I do feel like that is often a missed sign of hypovolemia or hypoperfusion. So completely agree with reiterating that point on exam findings. Thank you for that.
So one concept that's particularly important in trauma is what's known as this lethal triad of coagulopathy, with hypothermia and metabolic acidosis being contributors as well. These three factors all contribute to worsening bleeding. If you recall from physiology, clotting factors involved are enzymes that work at physiologic temperatures and pH. If the patient's too cold or acidotic, these coagulation enzymes stop working effectively. Blood will not clot properly, and the patient will have even worse bleeding. Additionally, if factors are diluted out by too much crystalloid, or the transfusions do not follow a proper ratio of 1:1:1 that's recommended, there will not be enough coagulation factors available to form clots. To stop the bleeding, a lot of our efforts are focused on breaking this triad. So there's actually a lot of things to unpack here, and there's a lot of nuances involved in this, but this speaks to why this 1:1:1 has been proven to be effective, why we've really diverged from giving too much just crystalloid up front, and why oftentimes as soon as patients come in, we focus on preventing or treating their hypothermia and resuscitating them appropriately to make sure that we don't fall into this spiral of this lethal triad of coagulopathy. Dr. Forrester, do you have anything to add?
No, I mean, I think it just underscores the importance of making sure that you address each of these components of the triad. And the one that we see kind of most commonly missed is hypothermia. And I think it's really easy to let patients get cold. But once they get cold, it's very challenging to get them warm, particularly when they're dealing with hemorrhagic shock.
I think some of the ways that we can warm patients and that we should think about is making sure that the intravenous fluids are warmed. If the other blood components are not frozen when we're transfusing them. If you are in a climate controlled environment, you can also raise the temperature of the room, and then keeping all exposed areas of the patient covered as much as possible. Obviously may not always be possible, but it's very important to keep the patients warm.
Yeah, it's a lot easier to keep a patient normothermic than it is to warm a hypothermic patient. So if you can prevent getting cold, that's your best bet.
Earlier on, Dr. Kimani discussed the major causes.
Dr. Papicho, sorry, can you unmute again, please?
I was saying earlier on, Dr. Kimani discussed the major causes of hypovolemic shock, and we mentioned to say hemorrhagic cause of shock was the most common. But it's also important to remind ourselves that loss of fluid can also lead to hypovolemic shock. And this loss of fluid can come from different areas. It can be from GID origin. A patient who's having diarrhea, profuse diarrhea, and we are not replacing any fluid, they're going to be into shock plus loss of other electrolytes. Vomiting will lead to shock as well. Loss of fluid from gastric tubes can also lead to shock if we are not replacing what the patient is losing. Another source of skin losses. Patient who just from going into a traumatic burn they lose so much fluid because the skin has been destroyed, and then there's no more protection for the fluid that are going to come out from the burn area. Another area that we should also consider, it's a patient who's receiving diuretic treatment. Okay, is going to lose so much fluid, and then they can also lose, go into shock if we are not replacing the fluid that they've lost. There's also what we call third spacing. Third spacing, it's simply a patient who seems to be in edema status, but that fluid is not in use by the body. This fluid has moved from the intravascular space to the non-vascular space. It's now into the interstitial tissues. So what can cause the fluid to move from intravascular space to interstitial tissues? There are a number of causes that can lead to that one. A patient who's got pancreatitis, patient with ascites. Okay, there can also be another causes that can lead to that one. A patient who's got high hydrostatic pressure, so the fluid can move from the intravascular space to outside the vessels. Loss of proteins, patient who's got malnutrition, patient who's losing protein because the liver is done. Low oncotic pressure can also lead to loss of fluid, move of fluid from intravascular space to outside the space, to interstitial space. A traumatic patient, increased permeability of the vascular can also contribute and lead to hypovolemic shock. So when the patient is in shock, it's better to assess what is the cause of the shock. If it's hemorrhagic, we deal with blood. If it's non-hemorrhagic, then there's loss of fluid. We identify where the patient is losing fluid from, and then we do a replacement of fluid based on the target point that we'd like to achieve.
So thank you all for the great discussion that we've been having so far. We are going to continue on and refer back to our patient, Mr. Chen. So listed here, his past medical history is congestive heart failure with an ejection fraction of approximately 40% and takes furosemide. He has a past surgical history of an appendectomy at the age of 14. And his social history consists of him being married with 4 children, works as a motorcycle mechanic, drinks approximately 6 beers on weekends, and smokes cigars occasionally. While in the emergency department, interventions that have been performed include a pelvic binder that was placed and massive transfusion protocol was activated. And after the resuscitation of 5 units of red blood cells, 5 units of FFP, and 5 units of platelets, the patient's vital signs had improved, with their updated vital signs of a heart rate of 100, a blood pressure of 110/70, and respiratory rate of 26, and O2 saturation of 95% on 6 liters. His labs were notable for a hemoglobin of 8, a creatinine of 5.4, a lactate of 7. And after you observe the patient in the emergency department for a standard period of time, you determine that he was stable enough to go for CT scan to evaluate his injuries. So CT scan results show that Mr. Chen has an unstable pelvic fracture with a large retroperitoneal hematoma. However, does not have any active extravasation seen. Therefore, there's no active bleeding ongoing that we can tell. The pelvic blinder has been appropriately positioned. Patient is also noted to have a grade 3 splenic laceration without a pseudoaneurysm or active extravasation. And there was a small amount of intraperitoneal blood noted.
So Mr. Chen is going to be admitted to the intensive care unit. General surgery and orthopedic surgery have been consulted. Fluid management has been conservative because the patient has a history of congestive heart failure. His vital signs are stable. His heart rate is 100. His blood pressure has been maintained at 110/70. Pulse oximetry is reading 95%. That's on room air currently. And his hemoglobin remained stable. It was 8 on admission, and then went up to 11 after transfusion of 5 to 5 to 5 blood components. And then after 4 hours, his hemoglobin again goes down slightly to 10.6. However, 5 hours later, there's acute changes in Mr. Chen's vital signs. His heart rate is now 130. Blood pressure is 85/55. Respiratory rate is 30. His pulse oximetry is still reading 95%, but now he's requiring 10 liters of oxygen per minute. He appears anxious and pale. His abdomen has increased in size with distension and tenderness. So what is the next best step? A, transfuse blood. B, order stat labs. C, transfuse blood and repeat his chest x-ray. D, transfuse blood and repeat his abdominal ultrasound. Or E, start furosemide for fluid overload, given his history of heart failure. So I'll give you about 15 seconds to put your answers in the chat box before revealing the answer and continuing the discussion. Okay, so we think the answer is D. We need to transfuse blood
Hello.
because he has had hypovolemic shock, and we probably want to repeat his abdominal ultrasound due to the increased distension and tenderness.
Hello. Oh, me siento. Me quiero con para fazer comigo.
So abdominal ultrasound, and specifically in regards to trauma, it's the ultrasound that is useful to perform is called FAST, Focus Assessment with Sonography in Trauma. What it does is it's going to evaluate if there's free fluid above the diaphragm or above, free fluid in the belly. And his repeat FAST exam shows that there's free fluid above the spleen. So blood is ordered and norepinephrine is started. General surgery is called and he's taken to the operating room. I posted the link on how to evaluate POCUS for those who are not familiar with point-of-care ultrasound. So Open Critical Care has a free pocket reference that gives step-by-step instructions for performing a FAST exam. You can see the link in the chat box. This resource also provides instructions on transthoracic ultrasound for cardiac volume assessment, DVT scanning, and pulmonary and lung ultrasound. You can access this useful resource by either clicking the link in the chat box or using the QR code on the slide. Bedside ultrasound is a very useful, non-invasive, and inexpensive way to assess patients and identify what type of shock patients are in.
So Mr. Chen was taken to the operating room with your general surgery colleagues, and post-operatively, they tell you that Mr. Chen had a splenectomy performed. He returns to the ICU he returns extubated, and the anesthesiologist tells you to make sure to resuscitate the patient very well, and they resuscitated the patient very well. He is off all pressors by the end of the case. His transfusion requirements remain 5, 5, and 5, with 3 liters of crystalloid given in the operating room. And normal saline is currently running for Mr. Chen at 150 cc's per hour. On arrival back to the ICU, you note that his vitals are heart rate of 80, a blood pressure of 128/83, a respiratory rate of 22, and his oxygen saturation of 96% on 5 liters. 3 hours later, the nurse calls you to bedside and says that the patient's oxygen requirements have increased now with an SpO2 of 91% on 10 liters oxymask. You note that he has bilateral lung crackles on auscultation when you evaluate him, and bedside ultrasound evaluation of the IVC reveals a collapsibility index of approximately 15% and an IVC diameter of 3 centimeters. So we'll give you a minute to answer the following question. What is the most likely cause of the patient's increased oxygen requirements? A, hemothorax, B, pulmonary embolism, C, fluid overload, D, postoperative pain, or E, pneumonia. And chest x-ray is above for reference.
Dr. Comiskey is much more generous than I am. She's giving you a minute to put your answers in the chat box. I give you like 15 or 20 seconds. So thank you for your generosity, Dr. Comiskey. Okay, 5 more seconds.
Okay, so time is up. The correct answer for the question is C, fluid overload. As you can tell, the chest x-ray is consistent with pulmonary edema, and his IVC is noted to be rather plethoric, as well as the volume resuscitation that he received in the setting of his congestive heart failure.
Dr. Papicho, are you able to tell us some of the endpoints of resuscitation when we know we have resuscitated enough?
Sure. And as we do our resuscitation, there's a target that we would like to achieve. Always remind ourselves that when you're dealing with patients, there should always be a limit in all that you want to do, because excess of everything can lead to another complication after you've done a great job throughout resuscitation. So hemodynamically, you would like to have a map that is above 65, within the normal range, 65 to 90, somewhere there. This map, when you have such a map, we are very sure that organ perfusion is taking place and the organ are going to get enough oxygenation as the blood is reaching there. Tissue perfusion is also an important thing. The central venous oxygen saturation, it's a measure of blood from the venous system, the blood that's returning to the heart. We measure it from the big vessels, the inferior vena cava, the superior vena cava. Usually it's measured from ICU. Specialized doctor will do that. And then the value of this measurement is to show you what is the oxygen extraction and utilization by the body. And this will show you that oxygen is reaching to peripheral tissues, and then the body is utilizing that oxygen. The organ function, you look at the kidney. That is the need of catheterizing this patient. When you have a patient in shock, as you are resuscitating them, it's better to fix up a urinary catheter so that you are able of measuring the urine output. And that urine output comes out, and then you know that my kidney are being perfused better, and then there's good outcome, which is in the range of 0.5 ml to 1 ml per kg per hour. So if the patient is like 70 kg, you would like to have in a range of about 35 ml and above per hour. Then you say, I'm achieving my endpoint resuscitation. A patient was a bit confused when he was into hypotension because the brain was not perfused so well. After resuscitation, after giving either blood or fluid, when the patient recovers a normal mental status, then you'll be happy to say, I've achieved a better endpoint of my resuscitation. Measurement of CVP, even though it's not everywhere where we can measure CVP, But if you can do it, when you achieve a CVP of 8 to 12 centimeters, then you are okay. You can say, my tank is well filled in, then there will be good blood circulation, and then my tissue are going to be perfused, and then you are happy for that.
So CVP measurement requires that you have a central venous catheter, typically with the tip placed in the superior vena cava. Not everywhere has central lines or the capacity to transduce central venous pressures. However, ultrasound is becoming more and more available. And when Dr. Comiskey was giving us the update on our patient, Dr. Chen, she mentioned that the IVC was not collapsing and it was greater than 3 centimeters. So looking at this pocket reference that is again available from opencriticalcare.org. The link should be in the chat. It's definitely in the WhatsApp group, and or you can use the QR code here. This is also called a subcostal or subxiphoid view with the ultrasound probe. So the probe is placed fairly flat, just underneath the xiphoid process on the patient. And you can see in the upper image, the IVC is very thin and very small. And then you can see in the lower image that it's quite large. So it's much larger. So you're looking at the IVC to determine if it's full or if it's not. Additionally, when you use M mode on the ultrasound device, you can watch how the diameter of the IVC changes with respiration. So if the patient sniffs or takes a deep breath and the IVC collapses, the amount of collapse can help you determine whether or not the IVC is full. So we described hypovolemic shock as a tank problem, and looking at the IVC can give us a little bit of an idea about whether the tank is full or is not. So looking at this table, I actually want to start with the row in the middle that says euvolemic. If you look at euvolemia, then the IVC diameter as seen on ultrasound should be between 1.5 to 2.5 centimeters. And when it collapses, it only collapses by 20 to 50%. And this would suggest that the fluid status is somewhat normal or and the responsiveness to fluid resuscitation or additional IV fluids would be variable. If you move one row up and look at the row that says hypovolemic, the IVC diameter is usually much smaller. It can be less than 1.5 centimeters. And then similarly, when the patient takes a deep breath or sniffs, then it will collapse by greater than 50%. And again, you can use M mode on your ultrasound device to measure the widest diameter and the most narrow diameter. And that's how you can tell how much the IVC will collapse. So patients that have a collapsible IVC that is of small diameter are more likely to be fluid responsive, which means they are more likely to benefit from additional intravenous fluids or blood. If it's a hemorrhage. The row at the bottom that says hypervolemic shows that an IVC diameter greater than 2.5 centimeters and that collapses less than 20%, that the patient's probably not going to respond very well if you give them additional fluids because they already have a lot of fluids on board. And so we would consider them hypervolemic. So they already have adequate fluid resuscitation. So again, in order to figure out how to do the IVC view on your ultrasound, you can use that pocket guide by Open Critical Care, and it will give you all the guidance you need about the size of the IVC as seen on ultrasound, in addition to how it reacts when the patient is breathing, whether it's collapsible or not. I think it's really important to understand that not only CVP, jugular venous distension, but also IVC, those values are always affected by whatever is happening in the right side of the heart. So if you have high intrathoracic pressures or some sort of problem with the right heart, you may see elevated pressures from that, and that doesn't necessarily mean that your patient is volume resuscitated. So you may have to move to more dynamic measurements of volume status, such as passive leg raise, pulse pressure, and or capillary refill, things like that to assess volume status.
Okay, so heading back to our patient, Mr. Chen, So you reassess him and you note that his repeat hemoglobin is stable at 10.8. His abdomen is soft without distension, and you repeat a fast and there's no signs of bleeding noted. His oxygen saturation is now 89% on 15 liters with a respiratory rate of 36. His blood pressure is now 90/42 with a heart rate of 115. What is the next best step for your patient? A, transfuse blood. B, intubate. C, start norepinephrine or noradrenaline and intubate. D, consult cardiology, or E, repeat a CT scan. And I will give you 20 seconds for this. 5 more seconds for everyone in the chat. Okay, so the correct answer for this patient is C. And the reasoning, I see a lot of B's and C's in the chat. So you would want to proceed with intubating the patient. However, you'd want to also start them on norepinephrine and noradrenaline at the same time in order to provide additional cardiovascular support. Because when you give them medications to induce for intubation, you run the risk of cardiovascular collapse with that. And so you want to make sure that you're resuscitating them and you have them in a good spot in order to proceed with intubation, especially if you're putting them on positive pressure. I see a lot of D's as well, which is something that you will probably end up doing, but it's not the next best step. So it's all about kind of your process of prioritizing different actions. And so cardiology is certainly a necessary thing to get on board. But I would start with at least stabilizing the patient with starting them on norepinephrine and intubating them. So, Mr. Chen, you put the patient on noradrenaline due to the MAP being 58, and you intubate him for hypoxemic respiratory failure. You notice on exam that he has prominent JVD or jugular venous distension, and his blood pressure continues to drop. Therefore, you increase his noradrenaline to 0.3 micrograms per kilogram per minute, and you add on vasopressin at 0.04 units per minute. So next question is, what would you do next? And given the scope of this talk today, we will put it on pause for all your answers because our next series will be on the topic of cardiogenic shock, which we are concerned about with Mr. Chen potentially. And so please stay tuned for our next lecture next month in January.
So we have a few minutes left. So we will take a minute to utilize our panelists and go through some of the question and answers that we have received throughout this webinar. So Dr. Comiskey, do you have an idea of some of the most common questions that have been put in the chat or the Q&A? You want to go through the Q&A?
A very big one that was asked a lot was, what was the certain amount of blood products needed or given, or how do you focus your resuscitation? And so if some of our panelists could further touch base on what are the endpoints that you're looking for when you're doing your blood transfusions. And then another question that was asked was, if you don't have blood products readily available, what would be your next choice of resuscitative measures or fluid management for these individuals?
So I might start to answer that, and then also ask Dr. Benjamin to weigh in a little bit on his opinion. But as an anesthesiologist, a lot of times these patients are in the operating theater, and the first thing that we do to determine how much to transfuse is we watch the surgical field and we watch the operating theater to determine how much blood we think the patient has lost. So especially in a trauma or a maternal hemorrhage, you can actually guess and kind of estimate to the best of your ability the amount of blood that the patient has lost. And so you want to at least give them that amount of blood volume back, whether that's whole blood or component therapy. So I think that's a good place to start. If the blood loss is ongoing and very brisk, you just keep transfusing. But you're also in constant conversation with your surgical colleagues on how well they are doing to control the bleeding. If they start to see that they have the bleeding controlled, that the bleeding is slowing down or the bleeding has stopped, then you want to kind of stop your transfusion or decrease your transfusion, reassess the situation. And that's when you start to look at some of the other endpoints of resuscitation that Dr. Papicho pointed out, such as pulse pressure, obviously blood pressure and heart rate. You can keep your eye on urine output. And then if you have the ability to put an ultrasound on the patient, then you can look at their IVC. You can look at whether or not their heart is hyperdynamic. I'd like to hear maybe from Dr. Sammy and Dr. Papicho their thoughts about how they manage an ongoing trauma or hemorrhagic patient, or maybe even Dr. Rachel when she's managing a maternal hemorrhage patient, to see if they have anything to add.
Sure, I can quickly start. So, a lot of it depends on the context and the scenario. So, when from Dr. Crawford's perspective as an anesthesiologist, the things that she described are giving her clues into what the status, the resuscitation status of the patient is. This differs a little bit from when the patient's arriving into the trauma base. So oftentimes we are already aware what the mechanism was before they reach the hospital. So that gives us some, as well as their vitals. So before they even arrive, we already have a mental picture of what their likely transfusion needs are going to be.
Thank you for your lecture.
What the sorts of bleeding potentially could be. When they arrive, we start putting together the story that we have with what our clinical examination is. And a lot of this comes down to experience and pattern recognition and just having a good picture of what a sick and bleeding patient looks like and be able to make that kind of analysis fairly quickly when they reach the door. As mentioned before, the most common cause of shock and trauma is hemorrhage, more than neurogenic shock, more than cardiogenic or even intracranial hemorrhage. It's hemorrhagic shock from bleeding. So even though some of those other things may be going on at the same time. So once we've decided that the likely cause of their shock is hemorrhage, then we start activating quite quickly our resuscitation and 1-to-1-to-1 or whole blood, depending on what the scenario is. After that, depending on how they respond, and this really just comes down to what their vitals and mental status is, if they haven't been intubated, then that's kind of what's guiding our transfusion. As they're transitioning either to the operating room or imaging or an ICU, depending on how they respond and what our fast examination shows, then it sort of becomes a little bit more nuanced in how we tailor it. So if we're still actively transfusing, their blood pressure staying low, then that's like the simple scenario. Obviously they're bleeding, no big deal. We go to the operating room, and then as Dr. Crawford mentioned, it's continuous conversation with the anesthesiologists about what we perceive their status to be. Of course, they're observing how much bleeding there is in the case, and then we kind of have an idea of how much needs to be given. But, if there's active bleeding, it makes it fairly simple. What makes it a little bit more complicated is when it's not totally clear how much bleeding they're actually having, and how much of this is a component of coagulopathy, potentially from the lethal triad that we discussed before. And I did see a question in the comment about using thromboelastography and how that guides our resuscitation. That is a very useful tool, but I would caution people from relying on it too much in the acute phase, because if you're getting that number when they hit the door, after you've resuscitated them, things are going to be quite different by the time you resuscitated them, and using that as a guide will lead you astray. It is very useful once they're out of that acute active resuscitation, active bleeding, hemorrhagic phase where you have a little bit more control of the situation. And it does help you kind of hone in on what their specific needs are in terms of their coagulopathy. And it does help us decrease the amount of products that we give. Oftentimes we're giving cryoprecipitate, giving less RBCs, maybe more targeted for FFP or platelets. And so that is more kind of a later phase, like slower resuscitation, usually in the ICU type of scenario. And then, of course, you have to add all these other adjuncts on what is their respiratory status, what is their IBC status. And this becomes quite complex because often patients are third spacing. It's difficult to differentiate between what their total body volume status is versus their intravascular volume. So this is why we have all these adjunct and tools to try to determine what their active resuscitation needs are. And depending on the institution, there's a lot of other machines and gadgets and things that you can use to help guide that as well. But the easiest thing to do is just put the ultrasound, if you have it available, put the ultrasound probe on. And the other thing I will mention, as we kind of demonstrated in the scenario, just because you've used it initially doesn't mean you can't use the ultrasound again, right? You can constantly go back, even if they're in the ICU, even if they're on the floor, put another probe on. And this is a perfect example of delayed splenic rupture that was not initially seen on the ultrasound, but then later on was seen when they reevaluated the FAST. So.
Thank you, Dr. Benjamil. That's a lot. It's a lot to manage. I'm wondering if Dr. Papicho, Dr. Rachel, Dr. Natalie, do you have some summary thoughts about how to manage this patient and or hypovolemic shock in general? And I think I'll start with Dr. Papicho.
Thank you very much, Anna. It's a first to mention that in our environment, maternal hemorrhage, it's a big cause of morbidity and mortality. So almost every day a woman died because of bleeding, and that is a big challenge in our areas. So these patients, they come from far, then for them to be referred to a center where they can take good care of them. So when they arrive, it's even difficult to estimate how much blood they've lost because they've been bleeding throughout transportation. And by the time they come, they are clinically pale, they are in shock. So all that you rely on is to give the blood that you have, and then you focus more on the endpoint that we discuss on for you to say that I've achieved my target or not. For as long as you are not getting those endpoints, then you continue for your resuscitation measures until you reach at some point to say now it's a bit satisfactory and the patient is stable for you.
Thank you. Dr. Rachel?
Just to add on to what everyone else has said, yes, at times in our low resource setting, getting blood can also be a very huge challenge. So as you're waiting to have that sorted out or have some rescue come through your way, you should consider giving the crystalloids and also the colloids. So that will also help to stabilize the patient as you're trying to get your blood products available. What we have in our settings most of the time is whole blood. So you'll have whole blood and FFPs. So the other blood products become quite of a challenge. So we've learned the tactics and ways of just working around with the crystalloids, colloids, and whole blood. Another good thing to just mention is you're trying to also understand or examine and see is a patient responding to the maneuvers or to the interventions that you're giving. You just don't want to give too much of it, and then now you'll tip yourself to pulmonary edema and all this congestive heart failure. So yeah, that's what I have to say.
Thank you, Rachel. Dr. Natalie, do you have any other thoughts?
I would say my take home from the talk is, especially in resource limited setting, tranexamic acid TXA has been proven to be beneficial and is cheap, and it could be given fast. So we could use it as a great adjunct as you're getting additional resuscitation going.
Yeah, I think tranexamic acid, when is it available, is very helpful. Dr. Comiskey, what are the things that you look at in order of priority, maybe, when you're trying to assess somebody who you think might be hypovolemic?
For me, I first make sure that it's actually a true hypovolemia. So I look at the patient's physical exam. Do they have adequate capillary refill? Do their mucous membranes look dry? Are they moist? Take into consideration the full clinical picture. So why would they be hypovolemic? Have they been having nausea, vomiting, and diarrhea, and inability to take anything by mouth? And Then I also look at their urine output. I think that's a huge indicator for their volume status and potentially hypovolemia. And if you have fresh set of labs, that will also be a good indicator. What's their creatinine looking like? What's their hemoglobin? And then you can also, as previously stated, look at fluid tests. So you can do like your leg raise. You can look at your CVP. Those are always nice adjuncts to add. And then always grabbing an ultrasound, I think, is a nice, easy, and inexpensive and quick intervention, and placing it to see what their IVC looks like, what their cardiac function looks like. Does it appear that their ventricles are pretty decompressed, and whether or not their IVC is big or small, as previously noted on the table that you had presented earlier. So I think putting all those things into consideration and then thinking about, does this make sense and why would they be hypovolemic, and then fixing the underlying cause is certainly the next step from there.
Thank you. Yeah, I think for me, just to kind of zoom out for the whole presentation and the whole case discussion, in my mind, I put things into categories. The first thing you want to do with hypovolemic shock is to recognize it. And so I think Dr. Benjamin mentioned this. Almost every single panelist has mentioned this. You want to recognize it, whether it's through physical exam, vital signs, the use of ultrasound. And then you want to respond quickly. If somebody is in shock, that is a medical emergency. It could be a surgical emergency. It's life-threatening. So when you recognize shock, whether it's hypovolemic shock, distributive shock, cardiogenic shock, or obstructive shock, you want to respond rapidly, because if you don't, the longer the patient is in shock, the more likely they are to have organ dysfunction and then death. So you want to recognize the signs and symptoms of shock. You want to be able to identify it using other tools such as labs or imaging. And then you want to respond really quickly. The other thing you want to do is you want to reverse the process. So whatever is causing the shock, in this case, hemorrhagic shock, you have to stop the bleeding. You have to stop whatever is causing that shock in order to reverse those processes and save the patient. One thing I think is really important in all types of shock is monitoring the patient. And sometimes I think patients don't do as well as they possibly could because we either don't monitor them closely enough, meaning we don't check their vital signs frequently, or we don't reassess. You may notice somebody's hypovolemic, give them some fluids or give them some blood, and then consider it the problem solved. But that's not always the case. So in this case discussion, it was a great example of how the patient did better, but then a few hours later, they did worse again because they had additional bleeding and additional trauma. So it's really, really important to remember, until your patient is completely saved and completely stable, you need to have a higher level of monitoring that patient. That means checking the vital signs, not every hour, but maybe every 5, 15, or 30 minutes. You need to check their vital signs quickly and often. If you have a change in their clinical status, again, you need to assess that patient at least every hour. If their clinical status changes, you need to start over. Look for other causes that would be causing the shock. Look for other insults or other things that need to be treated. Maybe they're hypovolemic, maybe they're hypocalcemic, etc. So it's really, really important to recognize what's happening, to respond quickly, and to reverse the process so that you can save that patient, because shock is definitely lethal and deadly if not treated quickly. Dr. Comiskey, unless you have anything else, I think I would like to just thank these amazing panelists for all of their contributions. Thank you to all the learners who joined us on this session, and we look forward to seeing you again. We'll see you on January 15th, where we will be discussing our third session about shock. This time it's cardiogenic shock. Again, everyone can access all of the slides. They're free for download. They're open access on the Learning Resource Center. You should also receive an email after the session, and you can complete an evaluation, and that's how you will receive your CME through Stanford University. And yeah, thank you to Dr. Natalie, to Dr. Papicho, to Dr. Rachel, to Dr. Sammy, and Dr. Joe Forrester. And you too, Dr. Comiskey, for your amazing moderation.
Thank you, everyone.
Thank you, everyone.
Thank you.
Thank you.
Thank you.
Thank you, everyone.
Thank you.
It's appreciated.
Thank you very much.
Thank you.
Thank you so much.
Very much,
Thank
everyone.
you.
Appreciate it.
Bye.
Very wonderful webinar.
Thank
Thank you,
you.
the organizer. Thank you.
Thank you.
Wish you
Thank
Merry
Thank you. Thank you.
Thank you.
Thank you. That was
Thank
a
you.
great presentation.
Fantastic.
Thank you, everyone.
Dr. Papito.
Thank you.
Thank
Thank you.
you.
Thank you.
Thank you.